So I want you to picture something for a second. Imagine a heavy, kind of oily, completely colorless liquid just sitting in a little glass vial.
Right.
You're holding it in your hand, and you know for a fact that if you drop it or even just bump it a little too hard, the resulting detonation is going to completely level the building you're in.
Yeah, it's terrifying stuff.
Right. It's a highly volatile industrial explosive. But now, take that exact same chemical, and I don't mean like a cousin of it or a derivative. I mean the very same molecule.
The exact same one.
And imagine placing just a tiny, tiny amount of it right under a patient's tongue. And within, like, 3 minutes, their absolutely crushing chest pain just vanishes.
It's wild, honestly.
Right.
It is one of the most jarring dichotomies in the entire history of science.
I mean, it sounds like science fiction.
It really does. But we are talking about organic nitrates, so specifically compounds like nitroglycerin. I mean, for over 150 years, clinicians have been using these, what we call vasodilators, to manage ischemic heart disease.
Yes.
And, you can find plenty of textbook arguments about the strict chemical taxonomy, like whether we should clinically separate organic nitrates from nitrites, but functionally, they're all bound together by this one incredible characteristic.
Which is what, exactly?
They act as exogenous donors of nitric oxide inside the human body. They literally deliver nitric oxide.
Yeah. And that dual identity is really the core mission of our deep dive today. We've got this huge stack of pharmacology and medical history sources, and we are going to get to the bottom of how nitrates actually work.
Yeah, there is so much to unpack here.
Definitely. We want to understand the specific cellular mechanisms that, open up the vessels to relieve angina, but we're also going to dig into the really frustrating reality of nitrate tolerance, which forces doctors into some very awkward prescribing habits.
Oh, absolutely.
And then later on, we'll look at the intense bioethical debates that have surrounded these drugs in modern clinical trials.
Because to really wrap your head around how a single molecule can be a literal weapon and a cardiovascular rescue therapy, you have to look at how it entered the human record in the first place.
The origin story.
Right. It has this fascinating, completely parallel origin story in the mid-19th century. Science basically stumbled upon its destructive power and its physiological power at the exact same time.
Yeah. The sources say the first synthesis happens in 1846 by an Italian chemist named Ascanio Sobrero.
Yeah.
He creates nitroglycerin, but he's so unnerved by how unstable it is that he actually tries to bury his own discovery. Like, he actively warns the scientific community against handling it.
Which was smart.
Very smart. But then he does something crazy. He actually tasted a tiny drop of it.
Which is just wild by modern lab standards.
Completely insane. But he documented that just tasting it gave him a violent pulsating headache.
And that was actually the very first documented physiological clue, though, Sobrero obviously didn't realize the significance of it at the time.
Right, he was just dealing with a headache.
Exactly. So the industrialization of the chemical actually fell to Alfred Nobel a bit later, in the 1860s. Nobel realized there was this massive market for blasting rock and building infrastructure.
But he had to solve the whole blowing up randomly problem.
Right, the volatility. And sadly, after a devastating factory explosion that actually killed his own younger brother, Emil.
Wow.
Yeah, it was tragic. But after that, Nobel figured out how to stabilize the nitroglycerin by absorbing it into this porous rock called diatomaceous earth.
And that's dynamite, right?
Exactly. He patented that mixture as dynamite in 1867.
Okay, so Nobel is building this global empire on explosives. But at those exact same dynamite factories, these weird medical clues start piling up.
Oh, the occupational hazards.
Right. The workers who are handling the raw nitroglycerin are showing up at the local clinics complaining of these severe throbbing headaches.
Yeah, because the physicians at the time were basically observing intense vasodilation. The chemical dust in the factories was being absorbed right through the workers' skin and lungs.
Just from the air in the room.
Yeah, exactly. And that caused the blood vessels in their meninges, so the membranes around the brain, to rapidly expand. The increased blood volume and pressure in the skull is what caused the massive headache.
And around the same time, there was a British physician, Sir Thomas Lauder Brunton, right?
Yes, Brunton.
He noticed that inhaling amyl nitrite, which is like a related compound, it lowered a patient's systemic blood pressure.
Right. He reasoned that, well, if you lower the pressure, you might reduce the resistance that a failing heart has to pump against. And by doing that, you relieve the chest pain that we call angina pectoris.
But I mean, inhaling a volatile liquid wasn't exactly a sustainable take-home therapy for patients.
No, definitely not.
So it was William Merle, right, in 1879. He's
Wow.
the one who formalized the clinical protocol we actually recognize today.
That's right. Merle published these case studies proving that placing just a tiny dose of nitroglycerin in a tablet under the tongue could stop an angina attack in like 1 to 3 minutes.
Which is incredibly fast.
It is. And he even rebranded the drug as trinitrin, so his patients wouldn't panic at the thought of basically swallowing dynamite.
Which, fair enough. But why under the tongue?
Well, the sublingual route was actually brilliant. It exploits this really rich vascular bed right under the oral mucosa. So the drug enters the systemic circulation immediately.
Okay.
And it completely bypasses first-pass hepatic metabolism. Because, if you just swallow a nitroglycerin pill, your liver enzymes will largely destroy before it ever even reaches the heart.
Oh, I see.
So Morel essentially established the pharmacokinetic template for acute rescue: rapid absorption, immediate onset, and a very short half-life.
Which perfectly sets up this incredible historical irony from the sources. Decades later, Alfred Nobel himself developed severe ischemic heart disease.
Yes.
So the very man who built an empire on nitroglycerin is told by his doctors in Paris to take it for his angina.
It's almost too perfectly written.
Right. And he writes in his letters that he found the irony just too bitter to accept. He reportedly refused the treatment, saying his doctors were basically asking him to consume the substance that killed his brother.
The irony is poetic, for sure. But, it also highlights this major gap in the medicine of that era. Nobel's doctors knew the drug relieved the pain. But if he had asked them how it worked on a molecular level...
They would have had no idea.
Exactly. They wouldn't have been able to tell him at all.
That's what I find so striking about this. They prescribed this literal miracle cure for a full century without actually knowing the mechanism of action.
Yeah, they were just flying blind, purely observing the clinical effects.
So when did they finally figure it out?
It actually wasn't until the late 1970s and 1980s that the black box was finally opened. And that eventually led to the 1998 Nobel Prize, which, again, is Nobel's legacy, wrapping right back around this drug.
For the discovery of what exactly?
For the discovery of the nitric oxide signaling pathway.
Okay, let's unpack that. How does the nitroglycerin pill actually become nitric oxide in the body?
So the key revelation was that organic nitrates are prodrugs.
Meaning they don't do anything on their own.
Exactly. They possess no intrinsic vasoactive properties themselves. Once a nitroglycerin molecule actually enters a vascular smooth muscle cell, it has to be enzymatically cleaved or broken down to become active.
Broken down by what?
Well, we now know that in the mitochondria, there's an enzyme called ALDH2. That stands for aldehyde dehydrogenase 2. This enzyme breaks down the nitrate, liberating nitric oxide gas directly inside the cell.
And the nitric oxide is the primary messenger, right?
Yes, exactly.
The sources say it diffuses into the cytosol and activates something called soluble guanylyl cyclase,
You got it.
which then kicks off the conversion of GTP into cyclic GMP. And it's that accumulation of cGMP that ultimately drives down intracellular calcium levels.
Which is the mechanical endpoint we care about here, because muscular contraction relies on calcium. Calcium binds with calmodulin to activate the myosin fibers in the muscle.
So if there's no calcium...
Right. By severely depleting the free calcium inside the smooth muscle cell, those fibers lose their ability to maintain tension. The muscle relaxes and the blood vessel dilates.
Okay, I really want to pause on that dilation part, because our sources highlight a massive misconception regarding angina and nitrates.
Oh, this is a big one.
Yeah. It is incredibly easy for you or me or anyone to visualize angina as just a pure supply problem. Like you have an atherosclerotic plaque blocking a coronary artery.
Right. A clogged pipe.
Exactly.
Right.
The heart muscle is starving for oxygen, and that ischemia is what causes the pain. So the logical assumption is that popping a nitroglycerin pill just dilates that specific blocked coronary artery to restore the blood flow.
It is a completely intuitive assumption, but it is physiologically inaccurate.
Wait, really? It doesn't open the blocked artery?
Not really, no. By the time a patient is actually experiencing ischemic pain from a blockage, the vascular bed downstream of that plaque is already maximally dilated.
Oh, because the body's already trying to fix it.
Exactly. The local tissues have exhausted all their own auto-regulatory mechanisms trying to pull more blood in. So giving a systemic vasodilator like nitroglycerin doesn't meaningfully widen an already fully dilated, hardened artery.
Okay, so what is it dilating then?
While at standard clinical doses, nitrates don't actually exert their primary effect on the arterial side of the circulation at all. They're profoundly selective for the venous system.
So we're dealing with venodilation.
Yes.
So if we think of the heart as a water pump that's struggling against a clogged discharge pipe, the nitrate isn't clearing the pipe at all.
No.
It's essentially just throttling the intake valve so the pump receives less water to move in the first place.
That analogy captures the hemodynamics perfectly. Veins are highly compliant capacitance vessels. They have much thinner walls than arteries, which makes them way more sensitive to that nitric oxide cascade we talked about.
So they stretch out easier.
Right. When the systemic veins relax, they expand, and they sequester or cool a large volume of blood. That pooling drastically reduces the amount of venous return going back to the right atrium of the heart.
Which is what doctors call reducing preload.
Exactly.
And reducing preload physically changes the actual geometry of the heart, right? Less blood returning means the ventricles just don't stretch as much when they fill.
Which brings us to Laplace's law.
Okay, hit me with Laplace's law.
Basically, myocardial wall stress is directly proportional to the ventricular pressure multiplied by the radius of the chamber.
So the size of the chamber matters.
A lot. By reducing the volume of blood entering the heart, you reduce the radius of the ventricle. A smaller, less distended heart experiences significantly lower wall tension.
And less tension means it doesn't have to work as hard.
Exactly. Since wall tension is the primary determinant of how much oxygen the heart muscle needs, the drug corrects the ischemia not by delivering more oxygen, but by vastly reducing the heart's metabolic need for it. You unload the pump.
That is just a brilliant physiological hack.
It really is.
But reading through this, because that CGMP pathway is so potent and systemic, manipulating it obviously carries some really significant risks, especially if another drug is interfering with that exact same cascade.
Oh, absolutely. This is where we run into some severe life-threatening contraindications.
Right.
Because the smooth muscle relies on a very delicate balance. While that guanylyl cyclase enzyme is busy creating CGMP to relax the muscle, the body also has a family of phosphodiesterase enzymes.
Specifically PDE5, right?
Yes, PDE5. And its sole job is to hydrolyze or break down the CGMP to stop the relaxation and restore normal vascular tone.
So if the nitrate is basically turning the CGMP faucet on full blast, PDE5 is the drain keeping the sink from overflowing.
That's exactly right, which becomes a huge critical issue when a patient is taking a PDE5 inhibitor.
Right. Drugs like sildenafil, which most people know as Viagra, or tadalafil.
Exactly. These compounds were actually originally synthesized with the hope of treating angina, oddly enough. Yeah. But they proved far more effective for erectile dysfunction and pulmonary arterial hypertension. They act as competitive inhibitors of that PDE5 enzyme. They literally plug the drain.
So let's say a patient takes a PDE5 inhibitor, right?
Yeah.
And then later they experience chest pain and place a nitroglycerin tablet under their tongue. What happens?
The biochemical cascade just goes completely unchecked.
Because the drain is plugged.
Right. The nitrate generates a massive surge of CGMP, and the PDE5 inhibitor prevents its degradation. So that accumulation causes extreme, unmitigated relaxation of the vascular smooth muscle globally, all over the body.
Wow.
The patient's systemic vascular resistance just collapses, resulting in profound hypotension. Their blood pressure bottoms out.
Which is incredibly dangerous.
Very. The perfusion pressure drops so low that blood literally cannot reach the brain, nor can the coronary arteries perfuse the heart muscle itself. It can potentially lead to a fatal myocardial infarction.
A fatal heart attack. And that physiological mechanism perfectly explains why emergency department protocols absolutely mandate asking every single chest pain patient about recent use of erectile dysfunction medications.
You have to ask. The sources note there is a strict 24 to 48-hour separation window depending on the half-life of the specific PDE5 inhibitor they took.
You just simply cannot overlap them.
No, it's a hard stop in cardiovascular pharmacology.
Yeah.
The synergistic vasodilation is simply too dangerous.
Okay, but let's say there's no other drug in the mix. Even just taking nitrates on their own, if you constantly push this vasodilatory pathway, the body's homeostatic mechanisms are going to fight back, right?
Fired it, yeah.
Because you can't just artificially pin the venous system open forever without the physiology attempting to compensate for it.
The body defends its baseline very aggressively.
Yeah.
And this introduces one of the most frustrating phenomena in cardiovascular care, which is nitrate tolerance.
Right.
And fascinatingly, the very first evidence of this adaptation came from those exact same 19th century dynamite factories we were talking about.
The sources talked about this. The occupational physicians documented a pattern they called Monday disease.
Yeah, Monday disease.
Mhm.
So when new workers started at the factory, they would suffer those intense, throbbing headaches from the ambient nitroglycerin in the air.
Right, the vasodilation.
But by Wednesday or Thursday, the headaches would just vanish. Their vascular systems had adapted to the continuous exposure.
So they built up a tolerance.
Exactly. But the real danger actually emerged over the weekend. They would go home, the environmental exposure would stop, and their bodies would rapidly lose that tolerance.
Oh, I see where this is going. So when they walked back onto the factory floor on Monday morning,
The sudden re-exposure just slammed their reset system. The sudden vasodilation, combined with a sort of rebound hypersensitivity in their blood vessels, triggered massive headaches, acute angina, and in some documented historical cases,
Yeah.
sudden cardiac death.
from just walking into work.
Yes, the cycle proved that continuous exposure blunts the drug's efficacy, but abrupt withdrawal creates a dangerous rebound effect.
And we actually see the modern equivalent of this when doctors prescribe those transdermal nitroglycerin patches, right?
We do, yeah.
The sources say if a clinician leaves a patch on a patient 24 hours a day, the hemodynamic benefits, like the preload reduction and the anti-anginal effect, will almost completely dissipate within just a day or two.
The clinical efficacy literally falls off a cliff. And the underlying biochemistry of this tolerance is incredibly complex. I mean, for decades, researchers argued over the exact mechanism.
Have they figured it out now?
We now understand it's multifactorial. Part of it is just enzyme depletion. You remember that ALDH2 enzyme in the mitochondria we mentioned earlier?
The one that breaks down the prodrug?
Right. Under continuous nitrate load, that enzyme becomes oxidized and inactivated. It literally just stops processing the prodrug into nitric oxide.
So the drug is there, but the body can't use it?
Exactly. But there's also the issue of oxidative stress. The source would point out that continuous nitrate exposure ramps up the production of reactive oxygen species, specifically superoxide radicals within the endothelium.
And those aren't good, right?
No, those superoxide radicals are highly reactive. They act as scavengers. They basically chemically bind to the nitric oxide before it can ever reach the guanylyl cyclase. They neutralize the messenger mid-flight.
Man, the body really does not want this pathway constantly open.
It fights it on every front.
Yeah.
Furthermore, the body initiates this systemic neurohormonal pushback. We often call it pseudotolerance. The kidneys sense this sustained drop in blood pressure, and they activate the renin-angiotensin-aldosterone system.
Which raises blood pressure.
Exactly. Sympathetic tone increases. The body releases catecholamines and vasopressin to force the vessels to constrict, actively fighting the nitrates mechanism.
It's basically like trying to cool a room by opening a window, only to have the thermostat sense the draft and kick the furnace into absolute overdrive.
That's exactly what's happening.
But the clinical workaround for this is what really shocked me in the reading, because it isn't some elegant biochemical fix. The standard of care is just to enforce an 8 to 12-hour nitrate-free interval every single day.
Yeah, that's the solution.
Like, doctors typically instruct patients to just remove their nitroglycerin patch at bedtime, essentially leaving them totally unprotected by the drug overnight.
It really is a stark admission of our pharmacological limits.
Yeah.
We intentionally subject the patient to a period of zero coverage just to allow the ALDH2 enzymes to regenerate and the oxidative stress to clear.
That feels like a massive compromise.
It is. I mean, nitrates remain unparalleled for acute rescue therapy like halting an active attack,
Yeah.
but their utility as a continuous 24-hour prophylactic is inherently flawed.
And, if the dosing regimen requires that much maneuvering just to maintain efficacy, it forces a really critical evaluation of the drug's overall value.
Right.
Does manipulating hemodynamics actually alter the disease progression? If a patient is taking these drugs after a myocardial infarction, a heart attack, do nitrates actually improve their long-term survival? Or are they purely a Band-Aid for ischemic pain?
Well, in the late 1980s, the cardiovascular community was actually highly optimistic that routine nitrate therapy would reduce mortality post-infarction. The theory was that the chronic offloading of the ventricular wall stress would prevent adverse cardiac remodeling over time.
Oh, that makes sense.
It does. However, the data from the 1990s provided a really sobering reality check. This was primarily through two massive randomized controlled trials, JESSE-3 and ISIS-4.
And given that we are just temporarily pooling blood in the venous system, I have to imagine the long-term survival data pales in comparison to therapies that actually target the underlying pathology, like statins or ACE inhibitors.
You're spot on. The trials confirmed exactly that. Enrolling tens of thousands of post-MI patients, GISC3 and ISIS-4, demonstrated no significant mortality benefit to routine nitrate administration.
Wow. Zero benefit to survival.
Right. Nitrates do not regress atherosclerotic plaque. They do not stabilize the endothelium against rupture. They are incredibly powerful symptomatic relievers, but they do not extend life in the general post-infarction population.
Which makes the subsequent chapter of this story so fascinating.
Oh, absolutely.
Because just as the field kind of accepted that nitrates don't confer a survival benefit, this new trial emerged that suggested they actually might, but only for a very specific demographic.
Right. This brings us to the African American Heart Failure Trial, or AHEFT, which was published in 2004.
Tell me about AHEFT.
So AHEFT investigated a fixed-dose combination of isosorbide dinitrate and hydralazine. Hydralazine is a direct arterial vasodilator, but crucially, it also has strong antioxidant properties.
Oh, and we know that helps with the tolerance problem.
Exactly. It neutralizes those superoxide radicals we talked about. So the investigators hypothesized that this combination might be particularly effective in self-identified Black patients with heart failure.
And what did they find?
The results were actually so robust-like, with significant reductions in mortality and hospitalization, that the trial was terminated early so all the participants could receive the therapy.
Wow.
Yeah. And this led the FDA to approve the combination under the trade name Bidil in 2005.
But, and this is a massive but, that approval came with an unprecedented caveat.
It did.
Bidil was the very first drug in U.S. history approved with an indication specifically restricted to a single, self-identified racial group.
And as you can imagine, the approval of Bidil just ignited one of the most intense bioethical debates in modern medicine, one that sits squarely at the intersection of genetics, sociology, and pharmaceutical commerce.
Yeah, the arguments in the medical literature present two fundamentally different views of human biology, and we really want to make sure we represent both sides of this ongoing debate clearly.
Definitely.
So on one side, proponents of the race-specific indication argue that AHEFT was basically an early pragmatic step toward precision medicine.
Right. They suggest that self-identified race might serve as a surrogate marker for underlying pharmacogenomic variations.
Like actual biological differences.
Yes. Specifically, the hypothesis here is that populations with African ancestry might have a higher prevalence of baseline endothelial dysfunction or lower nitric oxide bioavailability, so making a direct NO donor like Bidil uniquely beneficial for them.
Okay, so that's one side. But conversely, a really broad coalition of geneticists, sociologists, and bioethicists push back heavily against that framing.
Oh, very heavily.
They argue that race is a sociopolitical construct, not a coherent biological or genetic category. And from this perspective, using race as a proxy in clinical guidelines is scientifically imprecise and potentially dangerous.
Right, because it risks biologically essentializing social disparities.
Exactly. Critics argue that the differences observed in the trial could be driven by environmental stressors, socioeconomic factors, or just unmapped genetic variants that don't cleanly align with racial categories at all.
And there is also a significant commercial critique documented in our sources, too.
Oh, the patent stuff.
Right. The underlying drugs, so generic isosorbide dinitrate and generic hydralazine, they had been off patent for a long time.
They're cheap generics.
Exactly. So critics pointed out that obtaining a novel, race-specific FDA indication allowed the manufacturer to secure a brand new intellectual property patent for the fixed-dose combination,
Effectively monopolizing a highly lucrative market under the banner of health equity.
which is a heavy accusation.
Yeah.
The B-Bill controversy really remains a foundational case study in medical ethics. It forces clinicians and researchers to grapple with how clinical trials categorize populations, the validity of those variables, and the tension between statistical trial data and our understanding of human genetics.
It is a massive intellectual burden for a 19th century compound to shoulder.
It really is.
I mean, let's just zoom out and consider the sheer trajectory of this chemical today. We started with an unstable industrial explosive that literally terrified its own creator.
And fueled the dynamite empire of Alfred Nobel.
Right, and then we watched it become a life-saving sublingual rescue therapy. We explored how it unloads the heart by pooling blood in the veins, the incredibly complex biochemical dance required to avoid tolerance, and how its mechanism collides so catastrophically with PDE5 inhibitors like Viagra.
And we navigated how it transitioned from a symptomatic Band-Aid into the very center of a profound debate over pharmacogenomics and race in medicine.
But before we wrap up, there's one more thing. Because the physiological power of the nitric oxide cascade actually extends beyond both the industrial and the clinical realms.
Yeah, there is a completely separate cultural phenomenon built around this mechanism.
Our sources note the really pervasive recreational use of related compounds.
We are talking about alkyl nitrites, most commonly amyl nitrite or isobutyl nitrite. They are widely known in the nightclub and party subcultures as poppers.
Right.
Inhaling these volatile compounds triggers an instantaneous massive spike in nitric oxide. Users seek out the sudden, intense head rush and the physical sensation of warmth that accompanies that rapid vasodilation.
But given everything we literally just discussed regarding systemic vascular resistance and the potential for profound hypotension, treating that cellular pathway as a recreational thrill just seems exceptionally dangerous.
Oh, the adverse effects can be severe.
Yeah.
I mean, beyond the risk of fatal cardiovascular collapse if combined with other drugs, heavy use of inhaled nitrites can induce something called methemoglobinemia.
What is that?
Basically, the oxidative stress forces the iron in the hemoglobin molecule to change from its normal ferrous state to a ferric state.
Okay.
And once that iron oxidizes, it completely loses its ability to bind and transport oxygen to the tissues. You essentially suffocate at a cellular level.
That is terrifying.
It is. Furthermore, there is robust clinical documentation of nitrate-induced maculopathy, where the cascade causes severe, sometimes irreversible toxicity to the retina. It can permanently alter a user's vision.
It is just a really stark reminder of the raw, unfiltered power of the signaling pathway.
Absolutely.
I just want you, the listener, to sit with the sheer unpredictability of this molecule's journey. The exact same chemical structure that shattered Rock and Alfred Nobel's minds, earned a Nobel Prize for uncovering the secrets of our vascular system, sparked national debates on the definition of human ancestry in medicine, and drives the chaotic rush of a nightclub dance floor.
It's all the same key.
Right. A single physiological key, unlocking entirely different realities depending on whose hand is turning it.
It perfectly illustrates that in the realm of pharmacology, a molecule is never just a static tool. It's a highly dynamic participant in human history.
I couldn't agree more. Thank you all for joining us as we trace the explosive history and really intricate science of nitrates. Keep wondering, keep exploring, and we will catch you on the next deep dive.